Hello there.
Right.
Would you mind if I examined your heart? I'll need to take your pulse and listen to your heart and so on. Are you quite comfortable there?
Yeah.
Okay. I'm just going to start by looking at your hands. Would you mind stretching your arms out? Good. Turn your palms up for me. That's excellent. You can rest that down. Okay. I'm going to lift your arm up. Have you got any pain in your shoulder or your elbow?
No.
Good. Okay, just relax there. Okay, I'm going to look in your eyes. And open your mouth for me. Stick your tongue out. That's great. Okay. And look towards the wall for me. Chin up slightly. Good. I'm sorry if my fingers are cold. Just going to feel your chest now. Good. Okay, can I ask you to roll onto your side, onto your left side for me? That's great. And just pop that arm behind your head. Excellent. Okay, and now sit forward for me. That's great. Just breathe normally. Okay, now breathe in. Stop there. Breathe out. Stop there. And breathe away. Just lift your chin up for me. Just going to press on the side of your neck. And the other side. Good. Okay, I'm going to listen to the back of your chest now. Tap first. And take some deep breaths in and out for me. And out. Breathe through your mouth. And out. And again. And out. And again. And out. Great. Lie back for me. Okay, I'm just going to examine your tummy as well, if that's all right. Any pain anywhere? Great. I'm going to look at your ankles, if I may. Great. Thank you very much. This young man is comfortable at rest. He had a regular pulse at 60 beats per minute, which was normal in volume and character. His cardiac apex is undisplaced but is forceful and is accompanied by a prominent left ventricular heave. There's a palpable thrill and a corresponding pansystolic murmur which is heard throughout the precordium. Both heart sounds are audible and the second heart sound is normally split. Venous pressure was not elevated, there was no peripheral edema, and his chest was clear. He does have one splinter hemorrhage in his right hand, but there are no other stigmata of infective endocarditis. In summary, this gentleman has a loud pansystolic murmur and a left ventricular heave. The differential diagnosis for these clinical signs would be a ventricular septal defect or mitral regurgitation. However, he has no other clinical signs consistent with mitral regurgitation, and as such I think it is highly likely that this gentleman has a ventricular septal defect. He does not appear to be compromised by this VSD in that there are no signs of cardiac failure, although he does have a prominent left ventricular heave implying a hyperdynamic underlying left ventricle. There is no evidence of right-sided heart failure or pulmonary hypertension. When examining the cardiovascular system of a patient, it's important to start by generally observing the status of the patient and noting whether they're acutely unwell or comfortable. Then I think it's a good idea to work from peripheral to central, starting with the hands, the peripheral stigmata of endocarditis or congenital cyanotic heart disease that you might find, pulse, blood pressure, and then move to the chest itself. And once at the chest, you should follow the routine pathway of observation, palpation, and then auscultation. As you go, as you pick the signs up, you need to start making a differential diagnosis and then narrow that differential diagnosis down. While you're examining, you should also look for ways of narrowing that differential diagnosis down and for further information relating to the diagnosis and the functional status of the patient. In this patient's case, with the VSD, the most important sign to find was that loud pansystolic murmur with the accompanying thrill. In addition, you need to elicit the signs that would give you an idea of the impact of the ventricular septal defect on the patient's left ventricle itself. Whether there are signs of pulmonary hypertension, because those are the hemodynamic features which lead to complications. VSDs are often associated with other congenital cardiac abnormalities, so it's important to ensure that in your examination that you do not find signs of associated congenital defects such as Fallot's tetralogy or coarctation of the aorta, which this patient did not have. Ventricular septal defects could be congenital or acquired. The acquired form commonly complicate a myocardial infarction and so tend to be associated with an older age group. The congenital form is often picked up in childhood, and patients you will see in the exam will be young adults like the patient I have just examined. It is one of the most common congenital cardiac abnormalities, and estimates of prevalence vary between 1 in 500 and 1 in 200. The defect is usually in the perimembranous portion of the ventricular septum. The majority of these congenital defects do tend to close with time. 50% close by the age of 1 year. But again, patients you see will be ones who have not had spontaneous closure. Complications with persistent VSDs in adult life relate to the risk of bacterial endocarditis, and I believe all such patients should have antibiotic prophylaxis prior to dental work, although this is the subject of some scrutiny at the moment by the American Heart Association and the European Society of Cardiology. Other complications that can occur relate to the amount of shunting. As the shunt volume increases, when the shunt ratio goes from 1.5 to 2 to 3, the right ventricle tends to become overloaded and patients develop pulmonary hypertension, which in turn can lead to an Eisenmenger complex. And all of our follow-up is aimed at looking for early signs of that happening. And should there be any evidence of increasing pulmonary pressures, then that's an indication for intervention, which is usually surgical. Similarly, any patient who's had an episode of endocarditis should be considered for surgical closure of the VSD.